Hello, my name's James Rippey. This is a lecture on renal tract ultrasound, and it's an introductory lecture. What we're going to cover in this lecture is the normal anatomy of the kidneys, the ureters and bladder. Then we're going to go through the ultrasound technique and the normal ultrasound appearance of those organs. And then we're going to touch on some pathology, so looking at hydronephrosis, simple cyst recognition, ureteric calculi, and measuring bladder volume. This is a report form that's on our website. You're welcome to use it, and I use it as an aide-memoire. It tells us how to identify mild hydronephrosis and telling that apart from moderate and severe hydronephrosis, how to identify a simple cyst, and how to measure the bladder volume, and really works well in conjunction with this lecture. So first, the anatomy of the renal tract. I've used the visible body to make the various diagrams along the way. It's an excellent software tool. So let's think about it. Kidneys, ureters, and bladder. The kidney is a retroperitoneal organ. There's one on either side. It lies on the body of psoas and it moves with respiration. So it moves down when you breathe in, moves up when you breathe out, and it's usually 9 to 13 centimeters long. In longitudinal section, you can see that it's got a cortex, it's got medullary pyramids, there's a sinus which surrounds the collecting system and the ureter. And here you can see that it's very much a three-dimensional structure. The kidney is bean-shaped, and within it is this collecting system, and here you can see the minor calyces with their little cupped calyces draining into the major calyces and down onwards into the PUJ, into the renal pelvis and down PUJ and ureter. This is a medullary pyramid, one of the little arteries, arcuate arteries, and the cortex here. So firstly, the cortex. When we measure it, we measure from the outside to the top of a medullary pyramid, and that should be about 10 millimeters or more. If it's less, it means that there's some atrophy of the kidney. The color of the cortex, it's usually isoechoic, so the same level of greyness as the liver, or slightly hypoechoic relative to it. So about the same level of greyness as the liver. If the liver is brighter with fat in it, then the cortex of the kidney appears blacker, but that's usually because the kidney has got, the liver has got fatty infiltration, and that's where the pathology is. If the cortex of the kidney is brighter than the liver, then it's likely that the kidney's got disease. The next thing we think about is the medullary pyramids. These are hypoechoic relative to the renal cortex, so they're darker than the renal cortex, and they drain into the collecting system and each one of them has its own cup-shaped calyx. And next we've got the renal sinus with the calyces and collecting system. Now the renal sinus is what we usually see on ultrasound, and it's echogenic. It's bright, and it's this bit. It's a brighter white bit, and it's the fat that makes it stand out on ultrasound. And it surrounds the collecting system. And so while the medullary pyramids drain into the collecting system itself is usually collapsed because it drains freely and surrounded by the echogenic fat. These, as I said, these cupped minor calyces drain into the major calyces here, then into the renal pelvis and down into the PUJ and ureter. When we think of the vascular supply, the renal arteries come off the abdominal aorta, the right renal artery going behind the IVC, the left across this way and directly into the kidney. The drainage is again via the renal veins into the IVC. And those vessels branch within the kidney. Here you can see arcuate arteries forming, and there's very nice branching of both the arteries and veins as they supply and drain the kidney. So what about ultrasound technique and what it all normally looks like? Well, renal ultrasound is not straightforward because things get in the way. There are ribs, there's lung, and there's bowel gas, which all gets in the way. To get the best views possible, we use the curvilinear transducer, so that's the curved abdominal probe, the 2 to 5 megahertz one. And whenever you're scanning anything, you want to look in long axis and then in short axis. So one way and then perpendicular to that. And when you've got a good view, you then fan right from one side of that organ to the other side. So if you're in longitudinal view of the kidney, once you've got that good view through your acoustic window, you fan all the way to the left and then all the way to the right. When you're looking at it in short axis, transversely, you fan all the way up to the top and all the way down to the bottom. And search around till you find a good acoustic window. You're going to have to avoid those ribs and gas in lungs or bowel. And once you've found a good acoustic window, stick with it and get the patient to breathe in and out, moving the kidney through your field of view. Certainly angle your ultrasound transducer nicely through that window to try and get different angles, but also use the patient's movement to help. So when we think about the right kidney, you can look anywhere from the front to the side to the back, and you can see you've just got to avoid the ribs and you've got to avoid lung and bowel. And so you could put the probe posteriorly here, looking through psoas. You can put it at an angle here between the ribs, or here and go through the kidney, getting a nice view through kidney here down, through liver down to kidney. Or you can go anteriorly, but then bowel gas often gets in the way. But if the patient takes a deep breath, sometimes you can look and get a beautiful view that way. So move the probe around from one side to the other, trying to find the best acoustic window, and often, most likely, you're going to be here. So that right kidney is tricky, and here we are. You can see the probe here. You can look from the front, and here I am. Get the patient to breathe in and fan the probe one way, fan the probe the other way. So here, looking at this image, the patient breathes in, it brings the liver and kidney down. We fan one way and we fan the other way right through that kidney until we've seen it all from end to end. The lower pole here is being covered up by that bowel shadow and gas there. Okay, so you're fanning one way and the other. And here I am subcostally anteriorly. You can go around a bit further, and here we're going intercostal, and I'm fanning here, fanning one way, fanning the other way in that intercostal space. Unfortunately, in that intercostal space, you can see you look through the liver, which is lovely, you see the kidney, which is nice, but then you get that black shadow, which is as you try and look through a rib. So here's liver, here's kidney, and then rib getting in the way. But certainly in some patients, that's the only acoustic window you get, and so that's a nice one to know about. It also gives us that nice right upper quadrant view for the E-FAST scan we're trying to look at Morrison's pouch. You can go further posteriorly, and here you can see me scanning around here. Oh, stop that one, didn't want to do that. Play that one, there we go. Fanning from one side to the other, more posteriorly now. And here you can see that the kidney is actually closer to the probe because we're looking from around the back. You're getting a beautiful view, no ribs in the way, and this guy happens to have a very good acoustic window here. And you're seeing the lower pole nicely, which you weren't seeing from the front before. You're also not being obscured by ribs. So this is probably the acoustic window of choice in this gentleman. And you can see here the nice little hypoechoic medullary pyramids there. You can see the renal cortex, and you can see the echogenic collecting system. Once you've gone in longitudinal, go in transverse, and this is the view of the kidney in transverse, and scan again, right? Here we go, looking up here, right from top of the kidney, get the patient to breathe in, and that'll move the kidney down as you look down to the bottom as well. You can even go posteriorly, but that often involves rolling the patient onto their side and try and get a view from there. And you can see here we're still even posteriorly, when you're looking through those posterior muscles, you're getting a nice view of the kidney, rib getting in the way a bit there, but a posterior acoustic window if you need. So the right side, lots of opportunity to look through that liver. And this is what you see. At the front, you see the liver. This is bowel gas with posterior acoustic shadowing, often obscuring that lower pole, particularly when you look from the front. Here's psoas. Here are the vertebral bodies and spine. And this is diaphragm and lung. And that's kidney, nicely framed in the middle there. When you look at the kidney, those are the hypoechoic medullary pyramids. There is the cortex, which you can see is the same echogenicity as the liver, just as it should be. So medullary pyramids and cortex. And then in the middle is that echogenic sinus, the fat-filled sinus, which is bright. And within that you get some hypoechoic collecting system. Now normally the collecting system is collapsed and so you don't see any black right in the middle of the kidney, but if there's some obstruction, which can be physiological, like in pregnancy or patients on diuretics or patients with very full bladders, then you do see that collecting system in the middle. Now in this particular picture you don't see the nicely cupped minor calyces. I've ad-libbed a little with my diagrams, but certainly you get the general picture of what the kidney should look like. And you'll get used to that time and time again. And here it is in transverse, with the liver at the front. Here, some bowel with shadowing behind. Here, the psoas muscle. Here, the vertebral bodies with aorta and IVC. And then the kidney, gallbladder there. And kidney here, this rounded structure that you're seeing transversely now, like cutting a kidney bean in transverse or across its girth. And that with the relatively hypoechoic medullary pyramids, and then the surrounding cortex, and then in the middle, that echogenic renal sinus there, and in the middle of that, the hypoechoic collecting system. But sometimes that's vessels, not just the collecting system. So it's important to put colour Doppler on to see if that's just artery or vein, because often it is, or if it's a dilated collecting system. So that's the kidney and transverse section. Now the left kidney is harder to see than the right, and the reason is that the liver acts as a lovely acoustic window for the right kidney. On the left there isn't a liver, there's a stomach and this transverse and descending colon getting in the way of where the liver would be, and they're full of poo and air and you can't see through them nicely, and so you usually have to go further back on the right to get your view. You may have to roll the patient on their side or over and go through psoas posteriorly, or sometimes intercostally here. Probably the most common view is here, just cutting a bit through the spleen and looking even here to get a good view that isn't interrupted by this horrible air-filled stomach and colon. Okay, so you're going to put the probe almost on the patient's bed posteriorly to get an adequate view of the left kidney. And here I am doing just that. You can see here the probe almost touching the bed, looking intercostally, it's at a slight angle between the ribs as they come down this way, and here is the image that I'm getting with that probe in that position. Here it is in longitudinal, nice view of that kidney there, and fanning one way and the other, making sure that I'm not missing anything on either side of that kidney, looking firstly at the cortex, the pyramids, the echogenic sinus, and seeing if there's a distended collecting system in the middle, that hypoechoic bit, which certainly there isn't in this case. And then turning the probe to look at it in transverse, and here we are looking in transverse, and I'll play that, and you can see fanning right up to the top of the kidney and out the top there, and then slowly fanning down, 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 and all the way out the bottom. So really important that you go right from one side right to the other side, top to bottom, and make sure you don't miss anything. Okay, so transverse as well as longitudinal. And here's some pictures of kidneys. So this is a nice normal kidney, 9 to 13 centimeters long, very close to the surface, which means it must be scanned from posteriorly where the kidneys are close, looking quite normal. Here it is in transverse. Sometimes you see funny things in the kidneys, and here you can see a nice bright little white ring. This is an angiomyolipoma. Now this course isn't about recognizing that, but you should recognize that you sometimes see things that you don't know what they are, and that's when you need to ask for help. So a small renal cell carcinoma is very difficult to differentiate from this. The patient needs follow-up and certainly expert review. So if you see something strange, ask someone about it. So that's an angiomyolipoma. It's a benign tumour, but needs differentiating from an RCC. This is a very long kidney. We can remember 9 to 13 centimetres is the usual length, and this one is longer. It may be that their other kidney was taken out and it's a compensatory hypertrophy. It may be that in fact this is two kidneys which have fused together, and you can see this does look like a bit of cortex coming right through the middle, which may mean then that there's actually a dual or duplex collecting system, with 2 ureters coming down here. So think about if the kidney is big. This is a normal looking kidney. It's really important that you try and get to the bottom end of the kidney. So here we see the upper pole of the kidney, and then as I come down here looking for the lower pole, I think, oh yeah, there it is, but no, it's sort of going on. So that lower pole just isn't ending nicely here. And in fact, the orientation of the kidney is unusual. In fact, it's lying here in front of the IVC, and there's a vertebral body, and this is aorta here. So the lower pole is going over the IVC and over the aorta. And in fact, if I look anteriorly, here's the aorta, and here's that lower pole of that right kidney, and it's coming right across in front of the aorta and joining this left kidney here, and that's a horseshoe kidney. So think about whether you can see the bottom of the kidney. Make sure you fan right from one end to the other end, and make sure you see the end and both sides of the kidney as you scan. This is another funny kidney with a little blob on it. That's a renal cell carcinoma. So again, the tip is just ask for advice if you're not sure what you're seeing. You can get dromedary humps. The thing about ultrasound is you don't know what you don't know. So if you're not sure, please ask. You certainly shouldn't be making calls on things that look like funny lumps. Please refer on. All right, so let's talk about hydronephrosis a bit. It's divided into mild, moderate and severe. And it's a fairly simple dividing system. Mild hydronephrosis is where there's just mild distension of the collecting system. You still maintain that cupping of the minor calyces, and it can be physiological or pathological. In fact, most patients who've got acute renal colic present with mild hydronephrosis. But it can be, as I mentioned before, from pregnancy or diuretics or a very full bladder. So if someone's got a very full bladder, let them have empty their bladder and see if their hydronephrosis resolves, which it should over 10 or 20 minutes. Then we go on to moderate hydronephrosis. In moderate hydronephrosis, there's blunting of those calyces. So instead of being nice and cupped, they're rounded and clubbed. And that's moderate hydronephrosis. And in severe hydronephrosis, there's actually thinning of the renal cortex. And this particular illustration does show some thinning of the cortex there, but certainly you can get far more severe hydronephrosis, particularly chronically, where you get complete loss or marked thinning of that cortex, and you can hardly see any normal renal parenchyma. It's all just hydronephrotic tissue. And so here is a patient with mild hydronephrosis. You can see a distended collecting system. It's hard to tell whether they're cupped or slightly clubbed, but this is certainly mild to moderate hydronephrosis. Here's another example where you can see that there's a hypoechoic collecting system, and you can see the proximal ureter here as well, down as we follow this way, going down towards the bladder. So this again here, a distended collecting system and mild hydronephrosis. And here's another example. And we play that, you see that distended collecting system, hypoechoic, the renal cortex certainly maintaining its thickness there. And I dare to say that's mild with some maintenance of those nice little cupped calyces that you're seeing here. So mild hydronephrosis. This is now moderate, where we've still got nice renal cortex, but we've got clubbing here of the collecting system. Some people might say this is moderate to severe because maybe there is a bit of thinning of the cortex there. It's certainly a scale, and some people are better at it than others, but we'll go for a moderate here. And here again, a moderate hydronephrosis. Occasionally the vessels can look hypoechoic, or they do look hypoechoic in the center of the kidney, and just putting color on will tell you whether that's an artery or vein that you're looking at, or a distended collecting system. Here it is in transverse with that round renal pelvis, which is big and distended. And here's a severe hydronephrosis with thinning of that cortex. Definite clubbing there and thinning of the cortex there. And another example, we've got a thin cortex, and now this time very much more marked distension of the calyces and collecting system, so that being a severe hydronephrosis. Hopefully that's straightforward. Now on to renal cysts. Really all after this course I'd like you to be able to do is to define what a simple renal cyst is, because they're common. And if you see one, you don't need to do anything about it. Having said that, if you see a complicated renal cyst, it needs to be referred, because certainly malignancy can be cystic. Simple cysts can be cortical, so on the outside of the kidney, or involving the cortex, or parapelvic, so in or towards the middle. A simple cyst is anechoic and rounded. If it's complicated, so it's had a bleed into it, or there's pus in it, or there's malignancy within it, it may well be anechoic. A simple cyst has a thin wall, a thick wall being a sign perhaps of infection or malignancy. Generally, there should be no loculations within a simple cyst, although people will accept up to one very thin loculation as long as there's no blood flow demonstrable within it. There shouldn't be any solid components within a simple cyst, and it should demonstrate post-cystic acoustic enhancement. So if it's got all of those things, it's probably a simple cyst. And here's an example of a simple parapelvic cyst. It's rounded, it's got no real discernible wall, it's anechoic, there are no nodules, there's no flow within it. That's a simple parapelvic cyst. They're often more than one together, and here there's a small one and a second parapelvic cyst there, and here it is in transverse section. Here's a cortical cyst, and they can be any size. This is a small one, but sometimes they're this big. They're often single, but often multiple as well. And when there are lots and lots of them, you've got to think about polycystic kidney disease. And this case is one of polycystic kidney disease, where you can see the renal outline here, but there are also lots of liver cysts. So this is liver just up here. This is just riddled with cysts, and there's very little functional residual renal tissue left. That's polycystic kidney disease. So 1, 2, 3, okay. More than that, particularly if there's very abnormal looking renal parenchyma, think about polycystic kidney disease. This is complicated. There's some cystic structures in the middle of this kidney, and it's hard to tell whether it's hydronephrosis or parapelvic cysts, and that is a common cause of mistake. In this particular case, which we go to here, there's actually a combination, and there are a few small little parapelvic cysts here, but there's also some hydronephrosis here. It's overgained. This image is brighter than it should be, but it's a combination of parapelvic cysts and mild hydronephrosis. This time we've got a small kidney. Now, often end-stage renal failure kidneys do develop small cysts. This has got a cortical cyst in it. There's a tiny, tiny little bits of echogenic material within that cyst, and perhaps a nodule and some solid tissue there. And so I think for the non-radiologist, non-advanced ultrasound practitioner, certainly that would be one to refer. This again has a thickened wall and not clearly a simple renal cyst. So that one would be one to refer as well. As I say, often more than one. So, renal cysts in a nutshell. Now, kidney stones, renal calculi. Now, calculi, stones anywhere in the body, tend to have an echogenic or bright front surface, and then because they absorb lots of ultrasound energy, a dark or clean shadow behind the stone. Remember that air causes dirty shadowing and grey shadowing behind it, whereas stone and bone leave a dark, clean shadow. And when you put colour flow onto a renal calculus, they often twinkle at you, which means that as opposed to blood flow, which is all in one direction, and you either have blue or red flow generally, with twinkle, you get multiple colours all coming back at you from a stationary object. That's twinkle artifact, and I'll show you an example in a second. Renal calculi obviously can be in the kidney, where they often don't cause too many problems, although can cause pain, bleeding, and rhinitis for infection. You can get ureteric stones, which is the most common ones we see in the emergency department, patients presenting with renal colic, which can lodge either at the PUJ at the top end, halfway down or 2/3 of the way down at the pelvic brim, or at the distal end at the VUJ. You can get stones in the bladder which have come from the kidney or formed in the bladder. Certainly you can get stones forming in bladder diverticuli. And then occasionally we see a patient with a urethral stone. But usually once they've passed from kidney through ureter into bladder, they pass out the urethra without too much trouble. So here is a renal calculus. Here's a kidney, and you can see this bright shadow casting lesion at the lower pole of the kidney. So that is a kidney stone, and here it is behaving just as we'd like it to, shadowing very nicely with a bright echogenic front surface. So that's a kidney stone, and here is the transverse view of that kidney there with the stone and the shadow behind it. This is what I mean by twinkle artifact. Here we've got a stone towards the upper pole. These are blood vessels where there's blue and red, and this little bit is every single bit of colour from the spectrum of the Doppler spectrum here, from yellow through orange and red and dark blue and light blue and white. It's all in there. That's twinkle artifact, and that confirms that that's a stone. It does depend on your Doppler settings, and some machines you'll find it more difficult to demonstrate that twinkle artifact. So let's think about the ureters and the bladder. Here they are, running from kidney down to bladder. And we mentioned that stones gets caught at the PUJ, the pelvic brim, and the VUJ. Now with ultrasound, you can usually assess the first few centimetres of the ureter. You can often, particularly if it's dilated, look at the ureter as it crosses the iliac vessels at the pelvic brim, and then you can assess the very distal ureter. But in between those areas, you really don't get good views of the ureter normally. So here we have the kidney, and at the top end you can see there is mild hydronephrosis, and here we can certainly see a slightly distended proximal ureter. So normally when it's not distended at all, you wouldn't see it. This time we watch this distended collecting system, and here we see a bright shadow casting lesion. So here we've got this distension, and just here a big kidney stone stuck at the PUJ. It's about 14 millimeters of length when we compare it to the measuring here, and there is that stone. Echogenic shadow casting stuck at the PUJ. Here's another one, stone, the PUJ, big rib shadow here, but there you have it. Spleen up here, kidney here, distended collecting system, and big stone, 18 millimeters, blocking the way out. Probably needs something done about it. Here again, we can see a stone here obstructing that proximal ureter. And here's another one. There we go, that stone again, proximal ureter. So it's really pattern recognition. They look very similar, and it tends to be bigger stones that get caught up there, not surprisingly. When you're trying to look at the ureter as it crosses the pelvic brim, you need to press sort of fairly firmly here. Here's the umbilicus at the bifurcation of the aorta. Press hard in longitudinal here, take a cross section across these vessels, and you may see, particularly if it's distended, the ureter crossing there. And occasionally you see a stone as it sits just here, pausing as it dives over the pelvic brim. And here is the probe just here, and I'm fanning from side to side looking across, and here are those vessels, the internal iliacs in transverse, and over the top of them I'm not seeing a ureter at all because it's not dilated, although you could convince yourself that perhaps one of those small black lines is a non-distended ureter because this patient doesn't actually have a distended ureter. But here's the psoas, here's the pelvic brim, here are these iliac vessels, so pelvic brim, pelvis here, psoas here, vessels, and you'll see a dilated ureter as it crosses here and a little stone occasionally there. So there's the top end. As we follow down, here is a dilated ureter going over the pelvic brim. So here's the pelvis, here are those vessels, the iliac artery and vein, and there's a distended ureter as it crosses over the top. And then as it goes further down into the pelvis. But you lose it here and you can't see it again till you get right down to the bladder end. So how to search for those distal ureters. When we think about the ureters, they come in posteriorly on either side of the bladder at about the halfway zone. you see these seminal vesicles in the male and a prostate underneath it, and the prostatic urethra comes out here. And we're going to look from the front. Here you can see the prostatic urethra coming down. So we're going to look from the front, and we're going to put the probe on here and look back here. And so we can look in longitudinal and we can see the entire thing this way, or we can look transversely, and you're going to see this little ureteric outlet there as your probe cuts across. And so you're going to fan up and down, and this is really what you look at. You're trying to look to see where that ureter comes in. You can see the last few centimeters of the ureter, particularly if it's distended as it comes across and into the bladder wall. You can also explore the prostate and the bladder from top to bottom. So here again is that distal VUJ, which you can follow just from about here down and into the ureter, particularly if it's into the bladder if it is dilated. So here it is in cross section, the male bladder, and you're going to put the probe on anteriorly here to see if you can get your view. The problem is that you've got this symphysis pubis, which is shadow casting, and you can see that, so that cuts off that bit of view. And you often, unless you press firmly, you get a bit of bowel. Now, bowel full of poo and gas cuts your view as well with posterior acoustic shadowing. So you see this is nice clean shadowing from this bone. This is gas here, and it's got dirty shadowing. And so really, if I look like this, the only bit of bladder I can see is this little bit. So what you have to do is you have to push harder. And when you push harder, it pushes the bowel out the way. And then you're going to get a much better view of bladder here, because that bowel is going to be pushed out the way, and the bit that's obscured will get smaller and hopefully not be there at all. And then you've got to fan across the pelvis. Now, what do I mean by fanning across the pelvis? Well, here we have the ultrasound probe and beam, and what we're going to do is we're going to look right. Oh, what are we doing? Sorry. We're going to look right across this side to the iliac vessels, and then back. So now we're looking at the VUJ and that distal ureter, across to the midline, across to this distal bit of ureter, and right across to those iliac vessels. So you're going to fan one way and the other way until you've looked right through your pelvis in longitudinal. And here it is. We're going to do that. We're fanning right from one side, here are the iliac vessels, right across, down through prostate, right across through the other side, and here out the other side. So top of the bladder, bladder base here, iliac vessels one side, iliac vessels the other side, prostate in the middle, and the prostatic urethra through the middle. So that's the longitudinal view of the pelvis and bladder. And when we do that, we tend to save still images. So here we are right on the left hand side, and then slowly as we come across, this is not a very full bladder, so there's a little ridge in the bladder wall at the top. It's not a tumor, it's a ridge. You can see it carrying on. Here we go, right across from one side to the other side. When we're looking in transverse, which we always do next, we tend to need to fan the probe up, and you can see I move, we're looking just above the symphysis pubis here, putting the probe right down there and fanning upwards, right through the bladder, and then fanning downwards. Now we're looking at the VUJs and where ureteric jets would occur, then down, right down to the prostate. So right through like that. And here we have what we're doing here. Watch this here. You can see me fanning right down, and here we're fanning down. Here, the seminal vesicles. Here's the prostate, and right at the bottom now, out towards the bottom. Okay, so now we're going to start at the top again. Here, iliac vessels on the side. This is the bladder. We're going down, down, down. Now we see the bow tie shape of those seminal vesicles. We come down further. We're down at the prostate and right down through the bottom. We're going to see the ureteric orifices just about here. They're very hard to discern, but those little tubes going in there, ureteric orifices. And if you put color Doppler on those, that's when you see ureteric jets. Because every 20 seconds or so, the ureters squeeze a jet of urine into the bladder. They don't go symmetrically, but you sometimes see them without color Doppler. You can see them just if there's some sediment in the urine, it gets stirred up by a ureteric jet. But if you put color Doppler on, you see those ureteric jets perfectly. So here's that same bladder that we talked about, the ridge in the top of it going from top to bottom in transverse section. So here we are going in transverse. Here are the ureteric orifices here and here, and as we fan down through to the prostate and down through the bottom, and there is a ureteric jet, the patient's left and now the patient's right. Here's another one, nice bladder and transverse section. There's a ureteric jet and there's another ureteric jet. So you see them almost all the time. You won't see them if the patient's not well hydrated, and so you don't necessarily need to spend forever looking for them. If you've got a VUJ stone, you get, not surprisingly, a bright little thing at the VUJ with a black shadow behind it. And it often twinkles. And this is what we mean by twinkle. A little bit of yellow, a little bit of blue, a bit of turquoise and a bit of red. So that means we've got the entire spectrum of Doppler colour in that little twinkle. Here you can then try and put the probe slightly obliquely and get the distal ureter in line with the little stone in it, and you can measure the stone. It's not all that accurate because of beam width artifact, making it look wider than it is, but you can see the dilated distal ureter, you can see the stone in it, and the VUJ just there. Another stone here, and some twinkle on top of it. So here, a patient with a mild hydronephrosis, a distended proximal ureter, and then when you get down to the bottom end, here, a little stone with a little shadow behind it, and that dilated distal ureter as you're looking on the right. And then some twinkle, and you see that it's twinkling nicely for us under Doppler. So that's that little VUJ stone's only got a short way to go till it comes out. And there's another one, just a centimetre or two to go till it comes out with twinkle. And you can see this is a ureteric jet that's partially obstructed, but there is a little bit of urine getting through, and you can see that because of that sediment that's just rising there as that urine passes into the bladder there. So not a completely obstructed ureter, slightly dilated with that twinkle artifact. Another ureteric jet and another one. Sometimes you see something else in the bladder, and here is a little stone with a little bit of shadow behind it, and you look at it and you wonder, could that be in a distal VUJ? Well, you can see that this is on the patient as you're looking at the patient on their left posteriorly, which is near where one of the VUJs lies, but this patient is lying on their left side. So if you roll them onto their right side, that stone which was here is rolled right onto here. So now the patient has been rolled onto their side, the stone's rolled around, and that's how you tell a stone is actually through the VUJ, which can look like it's in the bladder because it's halfway through the bladder wall from one that's freely into the bladder. So this guy is probably going to pass this stone without too much further worry, and probably clinically they're feeling much better. Sometimes you see other stuff in the bladder. This is a transitional cell tumour. It's got a craggly outline. If you put some colour flow on it, it's probably got vessels growing through it. But sometimes sediment can look like that. Make sure you don't overcall things. Again, ask for help. Sediment, when you move a patient, will roll around. It won't have flow in it, but certainly you need to refer things you're not sure about. This is just simple prostatic hypertrophy. This is the middle lobe of the prostate. It's hypertrophied and growing into the bladder. It's not malignant. It's just a hypertrophied bladder, very hypertrophied prostate, a very big prostate, which then grows towards the bladder and will cause outflow obstruction at some stage. This is a trabeculated bladder, and you can see it's full of blood clot, and this is a catheter balloon. Now, again, you might think that that looks just like the tumour, and in fact it does. But here we have the catheter, the patient's got frank hematuria, and this is all blood clot. And that needs to get washed out with a 3-way catheter, and you may well need to do a proper vigorous washout with a 50ml catheter tip syringe, putting fluid in and out to try and break that clot up. But again, difficult to determine whether there is or isn't underlying malignancy there. So that's what a catheter balloon looks like in a big clot in the bladder. This is a small bladder diverticulum, and this is another catheter, a rounded balloon inside a bladder. Okay, so there's the catheter, here's the bladder wall, this is the longitudinal section, and this is the transverse section of that catheter in a bladder. Here we've just put a catheter in through this prostate into this bladder, and you can watch the catheter be put in, and then you can watch the balloon get blown up as well as it blows up. So very useful as you see the catheter pass, and then you know that you're actually in, and it's safe to blow up the balloon. So certainly in those very difficult catheters, I often watch to confirm that the catheter is passing. And sometimes ultrasound's amazingly useful, like this patient who has what looks like a bladder, but and a big bladder at that as well. Catheter was passed, but no urine came out, and caused a whole lot of concern. But actually, when you look at this, there's no catheter on this picture. And when you look to the side and the right adnexa, there is a rounded balloon sitting next to that cystic structure. And so then what you can do is you can deflate the balloon a bit, and you can see that this mass in the right adnexa is actually getting smaller. And here you can see the bladder wall. And this is the true bladder, which is fully compressed with the catheter in it. And this is a pelvic cyst, probably an ovarian cyst. So in terms of finding where catheters are, very, very useful. You can guide suprapubic catheters, and I've seen a couple of suprapubics go in through the anterior abdominal wall and then down and out through the urethra, and then get blown up in the prostate, which is an unhappy experience if you're the patient. And certainly now I use ultrasound to guide many of my catheters. The female pelvis is obviously a little bit different because you see a uterus behind the bladder. And here you can see this anterior view where the bladder's here, and here is the uterus, anteverted uterus sitting behind it. And we're not going to go through that in detail because we've done that in other lectures. You can see the female urethra here, the vaginal stripe here, the cervix here, and then that uterus, which is the same as this one, but it's slightly off to the side, so you're not seeing it in the midline shot. So that was the bladder. What about bladder volume measurement? Well, volume measurement's not too tricky. You get a nice view of the bladder in transverse, and you measure your X and Y axes. And then you get a view in longitudinal, and you measure your Z axis, and you times them all together. And you times that by 0.52, and that gives you your volume. So you use a formula that calculates the volume of an ellipsoid, which is X times Y times Z times 0.52, which gives you your volume. It's not accurate to the mil, but it's certainly not too bad. So measure the height, width, and length of your bladder, multiply those lengths, and divide by 2 or times by 0.52, and you'll get your bladder volume. Just going through this report again, you can see here some pictures of the kidney and bladder. You can draw on this bit to say what you found, and you can write your report on this side. And here's the aide-memoire, the mild hydronephrosis with dilation of the collecting system and retention of the cupped calyces, moderate hydronephrosis with dilation and clubbing of the calyces, severe hydronephrosis with increased dilatation and thinning of the renal cortex, simple cysts which are well defined with a thin wall, rounded anechoic cystic structures, no solid components, posterior cystic enhancement, and parapelvic cysts and an extrarenal pelvis can stimulate hydronephrosis. An extrarenal pelvis is where the renal pelvis is out here, and it can actually collect urine in it, which need not necessarily be hydronephrosis. It's just an extrarenal pelvis. Then in terms of ureteric jets, use colour Doppler and weight. Ipsilateral jet presence excludes complete obstruction, which makes sense. But if the jet isn't there, it doesn't confirm obstruction, because quite often a patient's just dehydrated and you're just impatient. Looking for VUJ stones, you may get a poor or absent jet, you may get hydroureter, and you'll get a shadowing echogenic little lesion with twinkle artifact at the VUJ. And to measure bladder volume, X times Y times Z times 0.52. So there's a report for you to use. And having just gone through all that, there it is again, but we've also got our parenchymal thickness of the cortex at 10 millimeters, the normal renal length written up there as well. So please use that if you want to. So just to reiterate, this lecture doesn't cover congenital and developmental anomalies. It doesn't cover complex renal cysts, and certainly doesn't make us able to diagnose and manage those by ourselves. It doesn't look at renal masses. It doesn't discuss renal trauma or renal infections. And the only way to get really good at that is to read more, to do more ultrasound, and to keep learning, which I strongly encourage. So, renal tract ultrasound, an introductory lecture.